morning from Miami Beach, home of Neurosurgical TV. We have the honor today of having the Iraq Neurosurgery Grand Rounds, headed by Samer Hose. I'll tell you, Samer, I'll just let you introduce Mustafa. Why don't we do that? Welcome, and let me just say a few words about Samer. He's been around a long time, and we started a while back with doing Google Hangouts, and we had some great shows. And Samer has a group. He's very active on social media, and he has a group of students that are interested in neurosurgery. He established a lab in Iraq, and maybe Samer can tell us a little bit about that. Hey, Samer, how are you doing today?
Hi, John. Hi, everybody. I am honored to be here again in the Neurosurgical TV. Actually, yes, we have a long time with the webinars, maybe 4 years or 3 years before the Corona era. And it was a good and fruitful experience with the Neurosurgical TV. Here in Iraq, we are doing the classic neurosurgery and more about the vascular and micro neurosurgery. And we are doing mentorship program supporting medical students interested in neurosurgery. Today, we have Mustafa Ayad Al-Murayati. He's a medical student in College of Medicine, Baghdad University in Iraq, and he will give a presentation about cerebral bypass. I want to ask if Mustafa want to start the presentation, please.
Yes, Dr. Samer, I could. Shall I start now?
Sure.
Yes, please.
Okay, I'll start sharing the PowerPoint.
Mustafa, you want to say a few words about yourself and stuff?
Yeah, of course. Hello, everyone. This is Mustafa Mrayati, a medical student at University of Baghdad, College of Medicine. I'm interested in neurosurgery, and today I'll be presenting a lecture about cerebral revascularization, extracranial, intracranial, and intracranial bypasses. In this presentation, I'll start by reviewing the arterial supply of the brain, and then I will explain what is cerebral revascularization and what are the indications of cerebral revascularization and what are the 4 main types of cerebral revascularization, and then we will discuss a few examples regarding this procedure. Starting reviewing the arterial supply of the brain, starting from the heart, we have the aortic arch that on the right side will give rise to the right brachiocephalic trunk. And then we have 2 subclavian arteries. The right one arises from the brachiocephalic trunk, and the left one arises as a separated branch from the aorta. And then we have 2 common carotid arteries. On the right side, just as for the right subclavian artery, it arises from the brachiocephalic trunk, while on the left, it arises as a separated branch from the aorta. And the common carotid artery will divide at the level of C3, C4 in the neck, the vertebral level, into the internal and external carotid artery. Indeed, the internal carotid artery will go into the brain and supply the brain and the eye, while the external carotid artery will supply the muscles of the head and neck and the structures of the head and neck. And then we have this central thing in the brain coming from the internal carotid artery. That is the circle of Willis. It has 2 lateral arteries. They would be the middle cerebral arteries, and 2 anterior and medial arteries. They would be the anterior cerebral arteries. That was regarding the anterior circulation, supplying the brain. Regarding the posterior circulation, it has 2 vertebral arteries coming from the subclavian arteries. They will unite in front of the pons to form the basilar artery, and that will contribute to the posterior circulation by giving the posterior cerebral arteries. Now we will talk about the external carotid artery. Here we are looking from the right side, the root of the neck. We have the right subclavian, the right brachiocephalic trunk, and here's the common carotid. And also it will give rise to the external carotid artery on the right side. And the external carotid artery has 2 terminal branches: the maxillary artery, which will run deep in the face, and the superficial temporal artery with its 2 terminal branches, the frontal and the parietal branch of the superficial temporal artery. Now, after viewing that basic anatomy of the arterial supply of the brain and the head and neck, we will discuss the principle of the revascularization. As we can see here, here's the external carotid artery running in the neck and then on the scalp, outside the skull, and its two terminal branches. Here's the frontal anteriorly, and here's the parietal slightly posterior to that trunk. And then we have the internal carotid artery. As we can see here in the neck, it comes inside the skull and supply the brain and the eye, as we mentioned earlier. And the internal carotid artery will give rise to a branch that will supply the lateral cortex of the brain, the middle cerebral artery, as we can see here as its shadow. And well, indeed, if we have a pathology, as you can see here, here's an aneurysm in the cavernous portion of the ICA. And if we did a ligation to that ICA, how can the blood flows distally in that ICA to supply that ipsilateral side of the brain? Indeed, if we just ligate that artery, we can make a benefit from the external carotid artery and its branch, the superficial temporal artery. As we can see here, after doing craniotomy, we are taking that frontal branch of the superficial temporal artery intracranially and anastomose it with a branch from the middle cerebral artery. That would be the anastomosis. So this is just a basic concept about the revascularization and the anastomosis. Well, we have a direct revascularization or direct bypass, in which, as we can see here, here is the superficial temporal artery branch from the external carotid artery being anastomosed with the middle cerebral artery directly. Or we have this also direct bypass, but using a venous graft or arterial graft. Here, as we can see here, this is just similar to a concept of the cabbage bypass in the cardiac surgery. And we are using a saphenous vein graft or a radial artery graft connected on one side to the external carotid artery or the superficial temporal artery. And also in the distal end, it's connected to the cerebral artery. For example, here is the middle cerebral artery. So bypassing the blood, if we have a compromised blood flow, and for instance, in this picture or this figure, we have a compromised right ICA. Now let's imagine the normal case scenario of how the blood should flows in the internal carotid artery, and I will demonstrate that by yellow arrows. As you can see here, the yellow arrows demonstrate the blood flowing into the internal carotid artery, and here is going to the bifurcation of the ICA into medial A1 of the anterior cerebral artery and laterally going as middle cerebral artery. That's the normal blood flow. But let's imagine if we have a compromised ICA and that blood flow will fade and it will be hypoperfused area. And the idea here of the bypass, we can use the external carotid artery, as I will demonstrate the blood flow into that artery as black arrows. As you can see here, it's going outside the skull indeed, not in the brain, and on the temple. And after doing craniotomy and bypass, we can anastomose the superficial temporal artery with the middle cerebral artery, and the blood will fill that area retrogradely to reperfuse and shunt the blood to that area to revascularize the area distal to the compromised ICA. That's the idea. Well, in revascularization, we have either direct or indirect bypass. The direct bypass, as I've just mentioned earlier, we have a vessel to vessel, and that would be an immediate revascularization. As you can see here, here's the superficial temporal, and here's the frontal branch of the STA, and here's, after doing craniotomy, we are anastomosing it directly with the branch from the middle cerebral artery, if we have, for example, a compromised left ICA in this figure. Or the indirect bypass, in which we are taking a scalp artery, for example, the superficial temporal artery or the occipital artery, and put it on the surface of the brain, cover it with the dura mater or muscle fibers, or even a omental graft, and that will promote new capillary formation and collateral circulation that will eventually should supply the brain. The idea about indirect bypass, it's revascularized with time. So the direct bypass, immediate revascularization, while the indirect, it needs more time. Now we will talk about the indications for bypass. Indeed, we have 4 indications: the cerebral ischemia or the TIAs, transient ischemic attacks, one of the indications, the Moye-Moye disease, which is the in which we have a hypoplastic C4, the supraclinoid segment of the ICA, and in the cerebral, giant aneurysms, which I will discuss in details in the next few slides, and even in tumors, especially the skull-based tumors. For example, let's see this picture. Here we have this is the ICA, the cervical segment of the internal carotid artery, and here it's engulfed by that tumor. It is a skull-based tumor, and as we can see, the lumen of the ICA, how it's narrowed, so the distal areas should be hypoperfused. So this is a compromised ICA on that side. So we can make a benefit from the vertebral artery as it's coming before it's making the basilar artery here. And by radial artery graft, as we can see here, here's a graft going from the vertebral artery, just more distal to the ICA on the MCA. Here's a middle cerebral artery segment. And the blood should flow from the vertebral artery to the middle cerebral artery and then retrogradally reperfuse the area that should be supplied by that ICA. That's an example of skull-based tumor. Let's see another examples about skull-based tumor. As we can see here, just for the orientation, here we are looking at the optic nerve coming through the optic canal along with the ophthalmic artery, which is a branch from the supraclinoid segment of the ICA. So here's the ICA, here's the C4 segment, and this should be the cavernous segment of the ICA. So this should be a cavernous tumor indeed, and the cavernous sinus. As you can see here, the nerves going, okay? And as you can see here, the tumor has occluded the lumen of the ICA, the cavernous ICA. So how the C4 segment of the ICA should get its blood if it's hypoperfused? Well, here's the bypass again. This is a right bypass using a radial artery graft to anastomose it between the superficial temporal artery extracranially and to intracranially, the middle cerebral artery. Here's the M1 segment. And as I mentioned, the concept of retrograde filling of the distal area, distal to the insult or the occlusion. Now we will talk about the four main types of revascularization procedure. The first one, it is the interposition vein graft, in which, for example, as we can see here, there is a cavernous ICA aneurysm, the cavernous segment of the ICA, C3, aneurysm. Here's the ICA for the orientation, and distally medial ACA and lateral MCA. After trapping that aneurysm by clipping it, we are interpose a vein graft that's a saphenous vein graft, just proximal to the clip and just distal to that aneurysm clipping. So the blood should shunt and divert it to that area to supply it. So that would be in type 1 bypass. That would be interposition vein graft. Type 2, which is extracranial to intracranial bypass with using of a graft. So for instance, here we have the supraclinoid ICA aneurysm. This is just proximal to the bifurcation to the MCA or on the ACA. And if we just clip that aneurysm and trap it there, how can the blood flows distally? So indeed, we are taking the external carotid artery, the superficial temporal artery in specific, and making anastomosis with the MCA by using an saphenous vein graft. Or maybe we can use in other conditions, the radial artery graft. So the idea here, we are using a graft. Type 3 bypass, in which we can use the scalp artery, either the superficial temporal or the occipital artery. That would be also extracranial to intracranial bypass. Let's see the image here. Here we have the MCA aneurysm, and we are taking, if we clip it and trap the aneurysm, how can the blood flows to the distal MCA? Well, we can take the superficial temporal artery and directly anastomose it on the distal MCA, distal to that aneurysm, to reperfuse that area. So how can type 3 differ from type 2 indeed? The idea here in type 2, we are using a graft, either a saphenous vein graft or radial artery graft. Well, in type 3, we are using the scalp artery directly. As we can see here, this is the superficial temporal artery without using a venous graft or radial artery graft. It's directly anastomosed into the cerebral artery. So that would be type 3 bypass. The last one is the direct intracranial bypass, in which, for instance, here we have the ACA aneurysm. As for the orientation, here we have the ICA bifurcation, the medial branch is the MCA, and the lateral is the MCA, and the medial is A1 of the ACA. So this is the anterior communicating artery. So it is an aneurysm in the A2 segment of the anterior cerebral artery. After clipping that aneurysm and trap it there, we are risking for the ischemia to the ipsilateral side of the area supplied by that ACA. So what's the problem? How do we solve this problem? Indeed, we can make a benefit from the contralateral ACA and make a side-to-side, as we can see here, A3 anastomosis to supply both area from the contralateral side to that aneurysm. So that would be a direct intracranial type 4 bypass. So now let's, in a simple diagram, discuss what is the bypass in cerebral aneurysms. Let's first imagine there's no aneurysm here and there's no clipping. So how the blood flows in that vessel? Indeed, it's coming from the proximal artery. The blood flows like that. But if you have an aneurysm, after clipping that aneurysm, how can the blood flows distally? Indeed, by using the alternative pathway we have made. This is the bypass, in which the blood is the flow is demonstrated in the green arrows, the new alternative pathway, and going distally. So that's the concept of bypass, in shunting the blood to revascularize the area distally. Now let's review the anatomy one more time for the vasculature of the brain, and then we will discuss what are these things. These are the cerebral giant complex aneurysms and the vasculature supplying the brain. And we will discuss each one in details, but first of all, let's get our orientation about them all. What are the vasculature here? Here we have the right common carotid artery, giving rise to here we have the external carotid artery, and here's the internal carotid artery. The ICA has 4 segments. This is the C1 segment of the cervical segment. Here's the C2 segment of the petrous, C3, the cavernous, and C4 is the supraclinoid segment. And here we have the lateral MCA and the medial ACA. That's regarding the anterior circulation. Regarding posterior circulation, we have 2 vertebral arteries, and then make the basilar artery, and then the PCA, posterior cerebral arteries. Now we will take each individual aneurysm. This is a complex figure, as you can see. Here are many examples of and different locations in cerebral giant aneurysms. We will discuss each one and with the treatment option. Indeed, we will progress from type 1 bypass to type 4, and we will see many aneurysms regarding the cerebral aneurysms may have more than one option to treat it. Not only type 1 or type 2, maybe type 1, type 2, 3, and some of which have only one type to treat it. We will discuss that. Now let's start with this aneurysm. This is a cavernous C3 aneurysm in the ICA. And for the orientation, you can see here's the petrous C2 and here's the distal C4. Supraclinoid, here's the MCA and the ACA. Let's focus on that cavernous ICA aneurysm. How can we treat it after clipping it off and cut the blood supply distally? So we can do that shunt. That's type 1 bypass. That would be the interposition vein graft. We are using a saphenous vein graft, so the blood should flows to the distal MCA, distal ICA, the MCA and the ACA on that side. Now we'll take another aneurysm. As we can see here, here's a cervical ICA aneurysm. This is a C1 aneurysm. After clipping that aneurysm and excise it, we are replacing the defect with a saphenous vein graft, and that would be also type 1 bypass interposition vein graft. We're interposing a vein graft into the vasculature. Here's another aneurysm. Here's a cavernous IC aneurysm. We've just seen the first option we have. Here's the second option. We can use a branch from this external carotid artery using a saphenous vein graft, and after clipping it to distribute the blood distally using a saphenous vein graft, that would be type 2 bypass. Okay, we've discussed type 1, which is the interposition vein graft to the same aneurysm here, but we have a different option here as the alternative type 2 bypass. Let's focus on this aneurysm. Here's a basilar artery aneurysm. After clipping that aneurysm, how can the blood flows to the posterior circulation? Indeed, we can make a type 2 bypass in which we can use the occipital artery, for instance, here, because we are dealing with the posterior circulation. We can use the occipital artery. This is a scalp artery, and attach it to the saphenous vein graft and anastomose with the PCA to supply that area with blood. Again, let's see this aneurysm. This is a supraclinoid C4 ICA aneurysm. After clipping it off, we are using the STA attached to the saphenous vein graft to do type 2 bypass. That would be extracranial, intracranial bypass using a saphenous vein graft. Here, another aneurysm. We can see here's the vertebral artery aneurysm. This is an interesting one. Indeed, you can see the pica artery, the posterior inferior cerebellar artery, arises just its origin taken from the aneurysmal part of the vertebral artery. So after clipping that aneurysm, we're risking for ischemia and hypoperfusion to the pica artery. So what's the solution? Indeed, we can take type 3 bypass, in which we are dealing with the occipital artery being attached directly without using a vein graft into the pica artery to reperfuse the pica also. Here we have another aneurysm. This is the third treatment option for that aneurysm. As we can see here, here's the C3 aneurysm. We are taking the STA directly and anastomose it with the MCA without using the vein graft. That would be also type 3 bypass. We've mentioned the two earlier options for that specific aneurysm, either type 1, which was the interposition vein graft, or type 2, taking the STA and attach it to the vein graft, or type 3, which is a direct STA to MCA bypass without using a vein graft. So we are taking that cavernous ICA aneurysm as an instance for multiple treatment option to deal with the ischemia distal to the clipped aneurysm. Here we are taking the MCA aneurysm, and if we clip that aneurysm, supplying the distal MCA with the direct branch from the superficial temporal artery without using a vein graft, so that would be type 3 bypass. Here we are talking about type 4 intracranial bypass. Here's an ACA. We have seen this example earlier. A3 side-to-side bypass after clipping that aneurysm. Here we are seeing the pica. Here's the pica aneurysm. The pica is a branch from the vertebral artery. If it has the aneurysm, we have two options now. Either just excise the aneurysm and then reattach the proximal and the distal artery, the pica. That would be also type 4. It's an intracranial bypass. We're not using anything extracranially, like the STA or the occipital artery, the scalp arteries indeed. So that would be type 4 bypass, or we can just clip the aneurysm and trap it there without excising it and reperfuse the distal pica with the contralateral side using a side-to-side pica bypass. That would be also type 4 intracranial revascularization. Now we've discussed all this complex giant cerebral aneurysms and what are the treatments we have to shunt the blood distal to the clipped aneurysm without risking to ischemia and infarction to the brain. Now we will talk a little more about the STA to MCA bypass. We have talked a lot about it, but we will discuss a few things. First, we have to localize the superficial temporal artery and its two terminal branches, the frontal and the parietal branch. And after moving all the muscles and the subcutaneous tissue, we are left with the superficial temporal artery, which is two terminal branches on the skull. After doing a craniotomy, we are exposing here the Salvian fissure, and by putting the artery, superficial temporal artery, on the cortex of the brain, and then expose the M3 segment, the opercular segment of the middle cerebral artery, and anastomose it with the superficial temporal artery. Here's the superficial temporal artery being anastomosed with the M3 segment of the middle cerebral artery. Now we have another concept regarding the STA to MCA only bypass. That would be only bypass, in which the difference here is that the superficial temporal artery, after the frontal branch, for instance here, after taken on the surface of the brain, and then make the anastomosis over there, and it's exit the skull once more time to the scalp. So here's the idea of the only bypass. We will discuss it. After taking or harvesting the STA, put it on the surface of the brain, on the pia mater. Here's the idea. We are tacking by suturing the superficial temporal artery to the cortical branches of the middle cerebral artery. They are the M4, in order to revascularize the M4 with blood from the STA with time. As you can see here, we are folding the dura to promote capillary formations also, and replace the defect in the dura with a synthetic dura. And after putting the bone flap, you can see how generous openings are left to prevent kinking as the STA enters and exits the skull. Here's the idea. Here's a cross section after doing only bypass. Here's the superficial temporal artery, tacking sutures to the pia mater and also to the cortical branches of the middle cerebral artery, the M4, to promote the revascularization to that M4 from the superficial temporal artery. Last but not least, we are talking about the bonnet bypass. It's really my favorite and an interesting one. Indeed, as you can see here, there's something bizarre going transversely through the skull. So for instance, if we have a compromised right ICA, as you can see here, this is the ICA, internal carotid artery. If it's compromised and we are thinking of doing a bypass, so we are considering the superficial temporal artery of that side. For instance, if unfortunate case scenario, this is a hypoplastic superficial temporal artery, and we cannot make a direct anastomosis between that STA and the MCA. So now we have an option to take the contralateral superficial temporal artery and diverting the blood through a saphenous vein graft drilled in a cave or canal inside the skull to go contralaterally and then in the Sylvian fissure to be anastomosed with the contralateral middle cerebral artery. So we are diverting blood from the left external carotid to the right internal carotid. Here's the idea of the bonnet bypass. As we can see here, here's the saphenous vein graft going transversely through the skull and its groove and coming from the right superficial temporal, for instance, and going deep into the Sylvian fissure to be anastomosed with the left middle cerebral artery. Here's really an interesting angiograph of cerebral arteries of a real patient. As you can see here, there's a bizarre thing coming transversely, and that is the bonnet bypass. Indeed, it's coming from the left superficial temporal artery, and here's the saphenous vein graft going transversely and being anastomosed with the middle cerebral artery. And you can see how beautifully the blood flows through the M2 and M3 segment of the middle cerebral artery. So here's an idea that we can peacefully sacrifice the right MCA, the right ICA without ischemia to the right MCA or the ACA in that area. Now, in summary, if we see here that we have an M1 bifurcation aneurysm, the MCA bifurcation aneurysm, so and the superior trunk and the inferior trunk coming from that aneurysm, after clipping that aneurysm, distally and proximally, we are risking of ischemia to the distal branches of the MCA. So the idea here to do bypass. Bypass is by taking and considering the external carotid artery and the superficial temporal arteries in special attention and see how approximate they are. They are indeed the MCA and the STA are just separated by skull bone. So after doing craniotomy, we can approximate them and anastomose them to make a shunt from the extracranial to intracranial bypass. That's one of the options. Now I'll leave you with a 1 minute video for Dr. Michael Lawton. He's doing
We're not supposed to get sound, right?
Yeah. I think there's a problem with the sound, but here's the pike
Okay,
arteries.
well, you want to run it again. Don't worry. This is very informal. Let's run it again. We'll run it again.
Okay, I'll fix the sound.
Because you have to kind of turn the option on for sound. I do actually. So let's approach this. I'm going to boot you off the screen there. This is going to boot you off. And then I want you to start fresh. Okay. Well, hold on. Let me put the share sound. Okay. Try it. Go ahead now. Go ahead now.
Okay.
The sound should come through.
Now, do you get the voice?
Can you hear? Well, that's not working either, apparently. Okay.
Okay. I'll comment on it.
Okay.
I'll play the video and then comment.
Okay.
Here's a pica bypass in the posterior. Here's the pica and the pica of the contralateral side. He's approximating them together nicely. And then suturing the two vessels. running continuous stitch, doing a nice approximation of these two arterial walls. That's good approximation and good communication. This green dye shows good filling. And this is the final, how you can see the spica and the pica, the contralateral side, being anastomosed side to side. Well, the references I depended on doing this lecture were 7 bypasses and the color atlas of cerebral revascularization. I hope you enjoyed all this presentation, and thank you very much.
Very good. Okay, excellent. Sam, are you there? He may have stepped away. Okay, there you go, Sammer. Okay.
Thank you, Mustafa, for the nice presentation. Actually, for the neurosurgery residents, this will be a very, let's say, intermediate level description of the bypass with its types. I think it will be fair enough for the residents, and I would thank Mustafa for being a medical student and just starting his 4th year in medical student and doing such a presentation with I think it's noticeable great anatomical orientation. I think this is the main message for the medical student, that the anatomy is the first pathway and the highway for neurosurgery. And for the resident, yes, bypass, you should have a general idea about it, supported by the anatomy, and to have a better understanding of the different types. And I think this is one of the most interesting aspects of in vascular neurosurgery that's still viable in these days, about the open vascular surgery, to do bypasses, and with time more and more bypasses will appear with different orientation or different aspects to find solution for a more and more complex vascular lesion. Thank you, Mustafa, for the presentation, and me and Mustafa, we are ready to answer any question, and I hope these are not tough one. Thank you.
Okay, very good. I just wanted to show Sammer, this is the webcast, as you probably recognize, that we did 4 years ago. Look at it, April 30th. With you remember that, right? MRID.
Yes,
Yeah, MRID, yes. And that was excellent. We had a couple of more. Now, can you can hear that? You can hear that, okay? Can you hear that?
Yes.
So loud.
Oh, okay. Well, you know, initially when I heard about, you know, bullet injuries from the sky, I assumed it was direct injury, but it's more like after celebrations that it's common, right, Sammer? Or people kind of cutting back on that?
Yes, sure, John. I think all over the world, there's different spots for celebration, or while during grave for dying people. There's
Right.
some firing.
In Brazil.
I think that was from Ammar Hadi from Samawa, Iraq. He's now, I think, in UK. And yes, it's a long time ago.
Yeah, and you know what happened, and you know, I explained to Mustafa about the networking possibilities that's afforded by this, but Ammar met a gentleman named John Byler, who's very active in trauma recovery of patients that have suffered trauma in the United States. He runs some organizations, and actually John and Ammar hooked up. And I don't know if Ammar came to the U.S., but I know those guys communicate pretty well.
Yes, yes,
and
he was
continued doing. Do you know what those guys have been doing at all? Have you familiar with that?
Yes, it's John Byler about the neurorehabilitation. I think the neurorehabilitation project.
Yeah, I'll try to find that. I'll try to find that while you guys are chatting. So, okay. Okay, any more questions from the panelists or comments for either Samer or Mustafa? It's a big day for Mustafa. He now is on tape giving a presentation
I
live.
I
Live
I,
to,
w-
go
I
ahead,
would
Samer.
I would highlight that John. Yes, it's the first presentation for Mustafa in neurosurgical TV. I think, and it's not my choice. It's his choice about the topic. He's already doing roton neuroanatomy for the last maybe 1 year, and preparing for bypass with different option, different books for the last maybe 4 or 6 months, just to show how deep is this topic. um, and I want to thank Volarex for the very nice demo or very nice presentation for Mustafa's lecture. And I think, as you said, Mustafa will never forget this illustration from Volarex. Thank you.
Yes.